Hello, everyone. Welcome to Emerging Therapies for Wet and Dry AMD. My name is Dustin Tenney. I am the Communications Director of the Macular Degeneration Association. We would like to thank Regeneron, Novartis, and Notel Vision for their support of our programs, both this one and the many others that we have available on our website at macularhope.org. We would encourage you to go and review and see what other additional programs you may like to sign up for and to view our virtual seminars there. A bit of housekeeping. We would ask that if you have any questions for the doctor at any point, that you please put them in the Q&A section on the bottom of your screen. Please do not raise your hand, and please do not wait to put your questions in. Feel free to put them in as they come up. The doctor will then answer them at the end of his program. The Macular Degeneration Association was founded in 2007 with the goal of finding the cure to macular degeneration. And as part of that goal, we want to educate people in our communities about this disease and about ways that you can help yourself now. So with that being said, we would like to introduce Dr. Joshua Green. Dr. Green is a board certified by the American Board of Ophthalmology and fellow American Academy of Ophthalmology. Dr. Green completed his fellowship at the Indiana University in Indianapolis, Indiana, and his residency at the Jewish Medical Center, New Hyde Park, New York. Dr. Green has been appointed Clinical Associate Professor of Ophthalmology at Shea Eye Institute, University of Pennsylvania School of Medicine, Philadelphia, Pennsylvania. Dr. Green practices at Philadelphia Retina Associates and is on the medical board for the Macular Degeneration Association. I'd now like to turn things over to Dr. Green.
Thanks for joining me today. Josh Green from Philadelphia. My practice is Philadelphia Retina Associates, and this is a fairly broad topic, and we've compressed it down to what I think are the salient points. Over the course of the next 50 or 60 minutes, we'll go over the condition, macular degeneration. We'll look at wet and dry and some of the treatments thereof. So let's jump right in. So what is macular degeneration? Let's start by talking about the eyeball. The eyeball is a hollow structure. It's hollow like a tennis ball. The inside of the eye is filled with a clear gelatinous material, and the retina is like the wallpaper in the back of the eye. And if you look at my schematic here, you can think of the eyeball as a camera with a lens in the front and film in the back. With this in mind, the eyeball is like a camera, and the retina is the film of the camera. Except in the case of the retina, the film is a light-sensitive layer of cells that collects visual information and sends it back to the brain. Now, the center of the retina is the focus area. We also call that the macula. That's the part of the eye that is responsible for central vision. Central vision is what we use to read, to drive, recognize faces, watch TV, look at the computer, etc. So it's really the business district, the business center of the retina. So macular degeneration as a disease selectively damages the center of the retina. It starts after age 50, and as we said, it can reduce the central vision, but it doesn't cause total blindness. When patients come into the office, the first question that they will often ask is, am I going blind? Macular degeneration is not the kind of condition that makes your eye go dark. You're not going to wake up and have total vision loss, but it does blur your center vision. In most cases, however, it does preserve some or all of the peripheral vision. And low vision therapies that you'll hear about later today take advantage of that. So there's two kinds of macular degeneration. There's the wet kind and there's the dry kind. Dry macular degeneration is it's an interesting disease entity. And essentially what it means is that the cells in the center of the macula, or in the center of the retina, are programmed to die before their time. The way that I usually explain it to patients is that the focus area, or the macula, is fading away slowly with commensurate loss in central vision. And if you look at the body of patients that have the diagnosis of macular degeneration, overall, 80 to 90% of those patients actually have the dry form. So the dry form is much more common than the wet form. And if we look at the pictures on the slide here, on the left-hand side, that is a normal retina in someone's left eye. And juxtaposed with that, we've got the left eye of a patient with dry macular degeneration. And if you look at the picture on the left-hand side, you can see that when we look in the back of the eye, this is what we're seeing when we look at patients in the office with our special lenses. The retina, although the retina is translucent, when we look at the back of the eye, there should be a uniform orange pinkish color to it. And if you look at the picture on the right-hand side, the kidney bean shaped excavation in the central portion of the photograph represents damage from the dry macular degeneration. So that's macular tissue that has literally faded away to nothing. Wet macular degeneration refers to the minority of patients that have the diagnosis of macular degeneration. In general, wet macular degeneration means that there are new, abnormal, illegal blood vessels that grow underneath the retina. And one important thing to note is that patients always start out with dry macular degeneration. Even if it has not been diagnosed, it always starts out as dry with those cells dying before their time, slowly fading away, et cetera. And then one or both eyes eventually convert from dry to wet. Now, even though wet macular degeneration only impacts a minority of patients that have the diagnosis macular degeneration, it is responsible for the vast majority of bad vision. So when you hear about vision loss in macular degeneration, usually they're referring to patients that have wet macular degeneration. So going back to our pictures here, the picture on the left is a normal left retina. And on the right-hand side of the slide, we see a patient with wet macular degeneration. And you can see that there's a hemorrhage located in the center of the photograph, which is not an uncommon finding in wet macular degeneration. So let's talk about some treatments. We've discussed what this is. What do we do about it? So really one of the pillars of treatment, if you want to call it treatment for the dry stage, is monitoring patients for conversion from dry to wet. As I said earlier, patients that have macular degeneration, they always start out with the dry macular degeneration and they convert from dry to wet. History has shown us, as well as clinical trials, that the earlier we get to patients once they change from dry to wet, the better off their vision is. So the Amsler grid is really a mainstay of monitoring for patients. So this is a picture of a woman using an Amsler grid, and we'll get a better look at that in a second. So an Amsler grid is usually described as a checkerboard box like we see on the slide here with a dot in the center. And patients are asked to use whatever glasses they use for reading or up close work, put those on and cover up one eye at a time and look at the dot in the center of the grid. And as we can all see looking at the slide here, the lines are all supposed to be straight. So any deviation from a grid of straight lines with a black dot in the middle is an abnormality that should be reported to your physician. So let's unpack that a little bit. These are some abnormal Amsler grids. On the left-hand side, this is a patient that can't see the dot in the center of the grid. And what that reflects is an abnormality in the central portion of the retina or the macula. On the right-hand side, it's really not blurring of the lines, but it's distortion of the lines. So you can see that the lines are really all straight and easy to visualize. They're not blurry, they're just wavy and distorted. And here's another example. This is a patient that has Amsler grid abnormalities that aren't really located in the center. We can see that the center dot is there. But if you look off to one side or the other, you can see loss of the lines in the lower left-hand portion of the grid and some distortion of the lines in the upper right-hand portion of the grid. So as I said earlier, early detection of that conversion from dry disease to wet disease is very important. The hemorrhage that I showed you in the earlier slide is really one of the most feared complications of this disease. A lot of patients will come in converting from dry to wet and they only have swelling in the macula. If they just have swelling in the macula, there's a good chance that we can stabilize or improve the vision. But once a patient develops a hemorrhage, recovery of vision is extremely difficult. So our goal is to get to patients before they bleed. Oftentimes the swelling is a precursor to the bleeding. And what we're hoping is that we can capture those patients with swelling before they progress to the more advanced stages of the disease. Most of the Amsler grids that we give out in the office, they have a grid on one side and then there's an eye chart on the other. It really allows patients and their caregivers to quantify what the problems are. They're able to say that the patient can usually read this line, which corresponds to a certain number on the left-hand side of the card, and now they can only read this line. So it really gives us important information about how quickly people need to be seen depending on the magnitude of their vision loss. And I can't stress this enough. The earlier, the better. I've had a number of patients over the years who we see on a monthly basis, and they will be doing fine 1 month, then they come in for their visit the next month and they've lost vision in one eye. And when I ask them about it, they say, well, I lost vision 3 weeks ago, a week after our last appointment together. And I asked them, well, why didn't you call me? Well, I didn't want to bother you. That's the reason we have an on-call phone number. It's specifically for patients to bother us for things like that. So we try and encourage patients to bother us with that information, even if it's after hours or on a weekend, because the earlier, the better. So you're going to hear more about this a little bit later on, but it bears mentioning. So there are some products out there that really piggyback on the idea of fastidious monitoring. So 4C Home, which again, you'll hear more about in a little bit, they've really taken home testing to the next level. So there's home testing equipment that they have in the house for you. It tests your vision, it generates a report and sends information to your eye doctor so that he or she knows if and when you need to be seen. It's a way to sort of automate the Amsler grid process to make it more efficient and more dependable. So patients with dry macular degeneration, and dry macular degeneration exists in various levels. In the clinical trials, they usually grade the dry macular degeneration grade 1 through 4. Generally, patients with grade 1 disease, maybe grade 2, can be seen every 9 to 12 months. Patients with stage 3 or 4 disease or grade 3 or 4 disease usually are seen twice a year. And your eye doctor will determine how often you need to be seen based on your level of disease, risk factors, et cetera. So management of the dry stage, of course, monitoring for progression to the wet stage. How about preventing progression to the wet stage? Is there anything that we can do to prevent the dry patients from turning into the wet patients? Because that's when disasters can happen. So we're going to talk briefly about the vitamins, and we'll, with that in mind, we'll talk about the age-related eye disease study, or the ARED study. This was a study some years ago. They looked at over 4,000 patients, and the initial ARED study looked at a combination of antioxidants and or zinc to see if it would impact the disease progression of macular degeneration and cataract formation. So the original AREDS formula was vitamin A, C, E, zinc, and copper. And with the original formulation, patients were told to take this with a multivitamin like a Centrum Silver or something thereof in order to combat the effects of the macular degeneration. Now, the AREDS supplement, the first AREDS supplement was successful for patients with a certain severity of macular degeneration. And so they did the AREDS 2 study. In the AREDS 2 study, there were a number of different changes. We're not going to go into all of that detail, but one of the things they did is they added macular xanthophylls. So these are macular pigments, lutein and zeaxanthine. And they also threw in the omega-3 long-chain fatty acids. And what they found is that in the original ARED supplement, which had vitamin A, which is also called beta carotene, there was some concern that increased vitamin A intake in people that were recent or current smokers, it increased their risk of lung cancer. So when they looked at the AREDS 2 supplement, they found that there was a benefit to getting rid of the vitamin A and substituting it with lutein and zeaxanthine. As far as the omega-3 fatty acids, they found they didn't really have an impact either way. So the standard for vitamins at present is this. It's the AREDS 2 supplement and a multivitamin, something like that. I have no financial interest in Centrum at all, but I thought that, picture is worth 1,000 words. But any multivitamin, whatever the multivitamin du jour is, would fill that box. And the AREDS 2, there's a lot of different companies that manufacture vitamins. And if they have the AREDS 2 label on them, it means that they have the combination of vitamins that was studied in the AREDS 2 study. And you have to be careful because sometimes they have the AREDS 2 combinations in addition to other things. So you have to be careful about what is in the bottle. It's very important to read the bottle and determine what else the companies have put into that. It's important to talk to your eye doctor before taking the vitamin supplements. It's not for everyone. Really, if you break it down, it's only for people that have stage or grade 3 and 4 disease, so more advanced forms of macular degeneration. Even though the vitamins they're widely given to a lot of patients that have lower levels of macular degeneration, patients that have a family history of macular degeneration, patients that are worried about getting macular degeneration. And there's been no level 1 scientific evidence to suggest that, giving it to someone with a family history lowers their risk of developing it. It's really been studied for people with more advanced forms of the disease. Now, some of the vitamins and the vitamin supplements are fat soluble, which means that they actually build up in your body if you take too much. So if you're going to take the vitamins and you haven't taken them before, it's important to coordinate with your family doctor, because he or she will have a list of all the medicines you're taking, hopefully all the other vitamins that you're taking, and they can make sure that it's safe for you to take the supplement. Smoking is bad. I'm sure that we've all heard that many times before. The clinical trials that have looked at smokers with macular degeneration really have horrific results. In some of the studies, it quadruples your risk of wet macular degeneration. So one of the most effective, potent lifestyle changes that we can recommend is for people to quit smoking. So don't smoke. Dietary carotenoids, these are naturally occurring dietary pigments, such as those found in green leafy vegetables, as well as yellow and orange vegetables. These are all good for the macula. When patients ask me about what they can do to help their disease along, whether it's dry or wet macular degeneration, besides the quitting smoking, what we tell people is that a lifestyle and a diet that is heart healthy is generally good for the macular degeneration. So anything that's healthy for the cardiovascular system is going to be good for the macular degeneration. Yellow and green vegetables, nuts and fish are also important staples in the diet. You don't want to overdo it on the nuts because they can be high in fat, but in general, nuts and fish are important. It's also important to reduce total fat intake. And if we think about this on the background of the heart healthy diet, heart healthy lifestyle, this all makes sense. It's really all in line with that. So reduced total fat intake, avoiding processed snack foods and baked goods, reducing your intake of red meat. This will all be good for the macular degeneration. Obesity and lipid levels. There's a positive association of obesity and elevated cholesterol with this disease. So high cholesterol, abdominal obesity can lead to progression of early disease to the more advanced stages. So again, heart healthy as well here. So let's go back to the retina. This is a normal retina of a patient's left eye. And these are different pictures of patients with dry macular degeneration. So let's back up for a second. Normal retina, you can see that there's a homogeneous orange color to the back of the eye. And then we've got different areas of patchy tissue loss in these patients. And, these represent areas where we not only have loss of retinal tissue there, but there would be corresponding blind spots. So if we really could accurately map out the vision loss in these patients, we would see that on the Amsler grid, the blind spot really mirrored the areas of geographic atrophy or loss of tissue that we're seeing here in the fundus photos or the retinal photographs. So these areas of tissue loss really correspond with blind spots. So what about treating dry macular degeneration? We've talked about lifestyle, we've talked about diet, monitoring the disease, the vitamins. There are some products which are, they're kind of far along in terms of clinical development. So there's APL2 and there's Zymura, and these are different medications that block what we call the inflammatory cascade, or the process of inflammation inside the eye. It's been thought for many years that inflammation really plays a key role in the progression of dry macular degeneration. And what they found is that by giving these medications to patients, they're not able to reverse any of the damage done by the dry macular degeneration, but they've been able to slow it down. These medications offer hope for patients that have dry macular degeneration, but perhaps they don't have any substantial vision loss yet. For those particular patients, these drugs are going to be very important because they offer the possibility of preserving vision. What about patients that have already lost a substantial amount of vision? Well, really, the therapy that holds the greatest hope for those patients are those stem cell therapies. So stem cell therapy refers to using cells that are effectively grown in the laboratory to replace dead or damaged retinal cells. And there's different protocols for how to put these cells inside the eye. Sometimes they're put on a scaffold or a holding block and inserted into the eye. Sometimes they're just injected underneath the retina during retinal surgery. But the end result is the same. These cells, they assume a place so they can replace lost or damaged tissue and actually restore some of that central vision. And they've had success in human trials. It's probably, we're probably a long way off from having this available to the general public. These therapies are very expensive and sometimes they have unpredictable results, but they do show significant promise to actually bring vision back, to improve vision in patients that have lost their central vision. So we've talked about the dry stage. We've talked about pathology. What are we seeing back there? Let's talk about management of the wet stage. So as we see from the photograph here, macular degeneration, whether it's an advanced form of the dry macular degeneration or it's wet macular degeneration, can give you the picture on the right-hand side, which is effectively loss of that central vision. So these are some of the treatments that we'll talk about today. It is definitely not an all-inclusive list because talking about all of the past, present, and potential future treatments for macular degeneration would be an entire day of lectures. And, we unfortunately don't have that kind of time, but we'll hit on some of the treatments that are being used and some future therapies. So thermal laser treatment was an older treatment for macular degeneration, but it's still used sometimes for patients. So thermal laser is what it sounds like. It's a laser that actually burns the back of the eye. It makes a burn. And what we're aiming to treat with the thermal laser are the new blood vessels. So we talked about wet macular degeneration, referring to new blood vessel growth, new abnormal blood vessels. They can cause swelling, they can cause bleeding, as we saw in some of the earlier slides. And what we're doing with the thermal laser is we're trying to cauterize those vessels and shut them down. Now, it's important that the new blood vessels that we're aiming to laser are not right in the center of the retina, because if they are, we can't laser those because we'll create a central blind spot for those patients. These are some patients. So the upper left-hand side is a picture of a normal right retina, and the pictures on the right-hand side in the lower portion, these are patients that have had thermal laser treatment for wet macular degeneration. And you'll notice that the changes that we're seeing on the retinal pictures there, they look a lot like those patients that had dry macular degeneration, because effectively what you're doing is you're creating patches of tissue loss that are just like the dry macular degeneration. So we don't want to create one of those patches right in the center. If you look at the picture in the upper right-hand corner, this is an older patient that had thermal laser treatment that really was a little too close to the center of the retina. Now the patient has a blind spot in the center of the retina. On the bottom, though, you can see that those burns were created away from the focus area. If you look at the picture on the bottom, the focus area is on the left-hand side of the picture, and the laser burns are all the way over on the right. So most patients that have wet macular degeneration are not eligible for this procedure because, unfortunately, for most patients, the new blood vessels start growing right under the center of the retina, and you can't zap them with the laser. I think that those numbers are an overestimate. I think actually only 5 to 10% of patients are eligible for the laser treatment. But when they're eligible for it, it can work really well. Sometimes a patient will have 1, maybe 2 laser treatments and not need treatment again for years. Now, because the thermal laser treatment actually creates burns, they came up with Visudyne, or photodynamic therapy. This is a laser type procedure. And what we do is we inject a special dye into the patient's bloodstream. And once that dye is circulating around the bloodstream, we fire a laser at the back of the retina. But the laser doesn't actually burn anything. What it does is it activates the dye that's in the bloodstream, and the activated dye selectively shuts down the abnormal wet macular degeneration vessels. It's a very elegant treatment. The science is really fascinating, and it worked better than the thermal laser treatment, but it still didn't work that well. We were able to stabilize vision in more people than with the thermal laser, but it still left a lot to be desired. So now we're going to talk about the standard of care. So intravitreal injections, which effectively means that the medication is injected inside the eye. So a needle is actually passed through the white part of the eye, which is the sclera, injecting the medication into the vitreous gel, which is the gel that fills the inside of the eye. And from there, the medication can easily make its way over to the macula where it's needed. So this is a schematic and a picture showing a patient getting an intravitreal injection. So the drug is delivered directly to the diseased tissue because it's injected right inside the eye. These injections are usually done in the office with sterile equipment, and it's actually a painless procedure. When I tell patients that they need treatment for wet macular degeneration or other retinal conditions that require injections, I get really a variety of horrified faces. But what I tell people, and this is the truth, it really is a painless procedure. We have very efficient, very effective ways of numbing the eye. These are some of the anesthetics that we use at the bottom of the slide here. and patients feel little to nothing. You definitely are not going to feel anything sharp when you get these injections. We numb the eye pretty extensively. And actually the anesthetics that you see at the bottom there, that is what they use to numb the eye for cataract surgery. So it provides adequate anesthesia for the cataract surgeons to do their procedure. Now, we're not doing surgery, we're just injecting the medication. So in and out very quick, and it provides adequate anesthesia. So why do we do these injections? Sometimes we inject other medications inside the eye, but what about for wet macular degeneration? What they found is that there are different hormones. Hormones are chemical messengers that float around our bodies. There are different hormones that play a role in macular degeneration, in the dry form as well, but this portion of the talk is going to concentrate on the wet form. So the VEGF, or vascular endothelial growth factor, the VEGF hormones, it's a group of hormones that is present all throughout the body, but it was found to play a critical role in wet macular degeneration. And what they found specifically is that the levels of these VEGF hormones were really high inside the eye. If you have really high levels of the VEGF hormones, you've got increased inflammation. They cause normally watertight blood vessels to begin to leak fluid, which causes swelling. And they also stimulate the formation of the new abnormal illegal blood vessels that I was talking about before. And the way that the medications work is that they block these hormones. And without these hormones floating around, the inflammation goes down, the blood vessels stop leaking, and the new blood vessels that are created, the ones that are bleeding or causing swelling, those vessels shut down. So there are different medications that actually achieve this. And this is another schematic of a patient getting an intravitreal injection. And you can see that when the medication is injected into the eye, it's really delivered right where it's needed, right to the macula, which is at the bottom of that schematic eye. Macugen was the first anti-VEGF medication. It was approved in 2004. And when Macugen was developed, they looked at the VEGF hormones and they said, you know what, VEGF 165, that's the one that's really incriminated in this disease. So we're going to design a medication. It leaves the other VEGF hormones alone, because the last thing you want to do is really indiscriminately block the effects of hormones all throughout the body. And they said, we're just going to hit this one. So they designed a drug to block VEGF 165. It was injected every 6 weeks. And what they found is that it worked better than the laser treatments they had before, but it still was not wonderful because it was a selective medication. And what that means is that it selectively blocked that VEGF 165. Because it was selective, they thought it would be safe in patients. And what I mean is that some of the other drugs we're going to talk about in a moment, they block all the different VEGF hormones. And there have been concerns over the years that by blocking all the hormones, you could potentially be increasing a patient's risk for stroke and heart attack. And so for a patient that had a recent stroke or a recent heart attack, many physicians at the time this drug was introduced felt that this would be a safe option for them because it only blocked one of the VEGF hormones. So 2 years after the Macugen was introduced, Genentech introduced Lucentis in 2006. This was similar to Macugen. It was an artificial antibody, and it was designed to block all of the VEGF hormones. So not just one of them, it blocked all of them. And the results were really just incredible. So it was injected on a monthly basis. And even though the Lucentis was designed to be given on a monthly basis, really in perpetuity, retina doctors have found different ways to achieve the desired results while not giving as many injections as monthly injections would require. So there are a minority of physicians that give injections every month indiscriminately. Some of us give the injections 3 on a monthly basis and then inject as needed. And other physicians bring patients in every few months and give them an injection at every single visit. They just see those patients less often. So there are different therapies, different protocols and strategies to reduce the number of injections that we have to give people without compromising vision. So with Lucentis, Lucentis was introduced. You had Macugen that was introduced a couple of years before, and then you had the laser treatments. Lucentis blew them all out of the water. The results had never previously been seen. In one of the studies that was done, over 90% of the patients had their vision stabilized or improved. So it was really, really dramatic. This was, what they commonly refer to as a game changer. Moving on to Eylea. So Eylea was the next anti-VEGF medication made by Regeneron. It was called the VEGF trap, and that really, doesn't apply to our discussion here. It just refers to the way that it blocked the VEGF hormones. So Eylea, like Lucentis, also blocked all the different forms of the VEGF hormones. And one of the things they found with Eylea is that it worked as well as Lucentis, but Lucentis, especially when it was introduced, it was thought that it needed to be given on a monthly basis in order to get the desired results. And what they found with Eylea is that it could be given every other month and get the same results as Lucentis. So that was huge. And actually, even today, most physicians will consider Eylea to be the most effective injectable medication. The newest anti-VEGF medication is BEOVU, made by Novartis. And according to the clinical trials and some of my personal experience with this medication, the BEOVU actually may work better than Eylea or Lucentis. It's an injectable drug, just like those other medications, and it really does a great job at shutting down the wet macular degeneration. Unfortunately, with the introduction of BEOVU, a rare side effect was seen. And this is a side effect that was never seen with Eylea, with Lucentis, or with another medication I'm about to mention. But they found that people were having blockage of retinal blood vessels associated with inflammation inside the eye. It's essentially like a retinal stroke. It was very rare, but we had never seen it with the other injectable medications, which is why it got so much attention. So this new side effect seen with BEOVU, in addition to the fact that it was introduced like a month or two before the world came to an end last year, really has limited the adoption of this medication. So there's not a lot of doctors that are doing BEOVU now, although it is available. Avastin is also made by Genentech, and it also blocks all the VEGF hormones. Avastin was developed and it was approved by the FDA to be given to cancer patients. So it was approved to treat colon cancer, lung cancer, ovarian cancer. And a pioneering ophthalmologist at University of Miami, Philip Rosenfeld, discovered that cancer patients that were getting Avastin as a chemotherapy drug had improvements in their retinal disease. So they took it a step further and they gave chemotherapy to patients with retinal disease, and it worked, but it had all the side effects of chemotherapy that you didn't want. So Dr. Rosenfeld and his colleagues decided to just take some Avastin out of the chemotherapy vial and inject it into the eye. And they changed the landscape of the retinal world forever. So Avastin does the same thing as Eylea, as Lucentis, as BEOVU, and Macugen, but the cost is a lot different, and we'll look at that. And the reason is because when you purchase Avastin, you're buying a chemotherapy dose, which, if it's broken down into little drops that are injected inside the eye, becomes very inexpensive. There are a number of clinical trials have been done looking at Avastin and comparing it to Lucentis, comparing it to Eylea, and they found that it works very similar to those medications, very similar. So it's an extremely effective medication, and it's received a lot of attention because it's a lot less expensive than those other drugs. Now, one of the concerns they've had with Avastin was not engineered to be injected inside the eye. So it's a much bigger molecule than Eylea or Lucentis. The reason that those other drugs were made as tiny molecules is so they could be cleared outside of the body quickly. Avastin hangs around in the eye longer than it's supposed to. And so there's some concern that if it's hanging out, it might be blocking more VEGF than they want it to. And circling back to our discussion before, it could potentially put patients at an increased risk for stroke, for heart attack, et cetera. So there are some concerns about those diseases in patients getting Avastin injections. This is the information about cost. So if you look at Lucentis, Eylea, BEOVU, they're around $2,000, maybe a little less, maybe a little more, depending on the dispenser. And Avastin, if you think about the cost of the chemotherapy dose and then breaking it down into individual doses for the eye, comes out to be about $50. And it's interesting because for years, there were many insurance companies that, in spite of the price difference, they wouldn't cover Avastin because they called it experimental, even though the use of Avastin was supported by more science than any of the other drugs, because a lot of different countries did their own clinical trials, they still wouldn't pay for it. Now things are changing, and most of the insurance companies actually require us to do Avastin first and then submit documentation to them that it's not working before they'll pay for the other medications. But Avastin works really well for most patients, not for everybody. Really, the decision about what medication to give you needs to be left in the hands of your physician. But many physicians do use Avastin by itself. Some other therapies that we'll talk about briefly. There's some really interesting stuff on the horizon. So gene therapy. When you think about gene therapy, you think about inserting a gene inside a cell in the body, to fix a problem. Well, what they've done with gene therapy in the retina, this is really tremendous. What they've done is they've turned the retinal cells into anti-VEGF producing factories. What do I mean by that? Well, what they do is these are two companies that are making gene therapy products for macular degeneration. There's REGENXBIO and there's Adverum, and these are their products. And what they do is they take an artificial gene and they insert it into a harmless virus. And the patients undergo retina surgery and have that virus injected underneath the retina with the REGENX product. And they have the virus injected into the eye, just like Lucentis, Eylea, Avastin, if it's the ADVM product. So under the retina or just inside the eye. And what happens is the virus infects the retinal cells, it puts the gene in place, and then the cells actually begin to produce their own Lucentis, Eylea, Avastin. And if this therapy works the way that the researchers hope it will, this potentially could mean an end to injections for patients that are getting these anti-VEGF injections, because now their cells are producing the drug. It really has remarkable potential. The port delivery system. So the port delivery system, or the PDS, is made by Genentech. That's the company that makes Lucentis and the company that makes Avastin. And what we're looking at here is it's a tiny plastic reservoir. And in order to put this in place, there's a minor surgical procedure, which is even less significant than a cataract surgery. But this little reservoir is implanted in the white part of the eye, and it holds Lucentis. It holds Lucentis. And what happens is once this little thing's in place, the reservoir can be refilled once or twice a year with a special concentration of Lucentis. And you can see from the schematic here that the needle from the special injector, it doesn't go through the eye wall anymore. It goes into the rubber stopper of the reservoir. So this really is a truly painless procedure because you're not passing through any eye tissues to get to the reservoir, just the rubber tip of the reservoir. So it's great because it'll make these procedures much more comfortable for patients, and it also lasts a very long time. It's possible that in some of the clinical trials, they found that a refill lasts for more than a year in certain patients. So the injections on a monthly basis, every other month, that is going to go the way of the dodo, as they say. So some other therapies that are on the horizon, faricimab, OPT-302, sunitinib. These are also injectable medications that have various platforms that allow them to stay inside the eye for a longer period of time. So most of the companies recognize that the injections work really well for people, and they work better than any of the therapies we had earlier, any of those lasers that we had for patients. The problem is that the burden of getting monthly injections or injections every other month is very difficult. Patients need to miss work, or their caregivers need to miss work. There are costs associated with coming to the office all the time. So people are really looking for a way to maintain the efficacy, keep the good vision that they're getting with these medications, but reduce the treatment burden. And these are some of the medications that will do that in the future. And I think that is it. Thank you very much for your attention. Okay, so first question. Do we know how long the average patient has dry AMD for before transitioning to wet AMD? That's a very good question. There are a lot of variables that impact the answer to that question. Genetics, the patient's appearance of their retinal examination. Some patients, I don't mean to give the impression that every patient with dry is going to get wet macular degeneration. That's not the case. A certain percentage of patients with dry are going to end up getting wet macular degeneration. I think if you look at the body of patients that have the diagnosis of macular degeneration, overall, the risk of progressing to wet macular degeneration is about 30% in 10 years overall, but that changes depending on genetics and what we're seeing on the retinal examination. Is there any way to predict which patients will transition in the near future? That I think I kind of answered that one. The best thing to do in order to keep those answers close is to make sure that you get regular eye exams, because no one's going to be able to answer that question more accurately than your healthcare provider that's examining you. They will be able to tell you that with the greatest certainty. Which insurers cover the foresee home? I don't know, but I think that there's an expert on that coming up and they will be able to answer those questions. If stem cell therapies cure dry AMD, does that remove the risk of wet AMD? These are really awesome questions. The answer is probably no, because the genetics of macular degeneration are extremely complex and they're always discovering new genetic abnormalities that play a role there. So the short answer is it does not reduce or change the risk of wet macular degeneration, but we may be able to mitigate that in the future with different medications and therapies. Is there any evidence to support taking turmeric as an anti-inflammatory? Okay, I don't know about turmeric, and I want to make a statement about turmeric and other holistic therapies. It's not to say that these therapies don't work, because some of them have been around for thousands of years, and there's information to support their use. The therapies that we recommend in our office are therapies that have been backed by randomized controlled clinical trials and level 1 scientific evidence. And the reason that a lot of the holistic therapies aren't offered by more mainstream physicians is because we don't have that level 1 scientific evidence to support their use. But that does not mean that they don't work, because I'm sure a lot of them do work. We just don't have enough information, because quite frankly, no one's going to sponsor $1 billion clinical trial to see if some of these medications will work. So the best I can tell you is I don't think that there's any harm will come to that, but I would make sure that it's safe with other medications that you're taking, and I would check with your primary care physician. There are a lot of treatments for wet macular degeneration. What is being done for dry? So there are a number of treatments for dry. I mentioned two of the products in the talk, APL2 and Zymura. These are injectable medications, and hopefully they'll be approved in the next year or two, and they are to slow the progression of dry macular degeneration. The stem cell therapy that I mentioned, which is probably 5 or 10 years off, that can actually restore central vision in dry disease. Okay, we know that diet, overall health is good at helping to ward off dry macular, but that just doesn't seem enough. What is being done research-wise? So in a patient that is taking care of themselves, not smoking, good diet, vitamins, etc., it's entirely possible that you are doing all you can to protect yourself. There's no such thing as 100% protection. And the reason for that is that the genetic abnormalities that are involved in both the dry and wet macular degeneration are varied, and they're not completely understood. And so quite often I'll have a patient that is really doing everything that they can to prevent the progression of the disease, and bad things happen sometimes anyway, and sometimes there's nothing you can do about it. There's no such thing as 100% protection. Sometimes you can only do what you can do and accept that your risk is lower than it would otherwise be. I've heard that too much zinc can cause the macular degeneration progress. Is this true? How do you know if you would be affected? This is a controversial issue. I know that we hit this on one of our past meetings with this organization. There's evidence to say that it's true and evidence to say that it's not. I generally, I advise patients about taking zinc, although there are some genetic tests that can help determine whether the zinc will be a problem for you. We don't run them in our office, but those genetic tests are available. My parents had macular degeneration and lost their vision, couldn't drive or read. Well, I developed macular degeneration. Is there a test that I could take? Regular eye exam. I would get a regular eye exam. Any eye care provider is going to be able to look at your retinas and tell you whether you're at risk for the macular degeneration. And one thing to remember is that when your parents had it, depending on how many years ago they had it, the likelihood is that they didn't have the treatments available that we have today to preserve vision. We're able to save vision in a lot of people that we could never do before. I live in the Bay Area of California. Can you recommend the best doctor institution for AMD? I'm 78 and have dry AMD. I lost central vision a few weeks ago. Unfortunately, being based out of Philadelphia, I'm not very familiar with the physicians in the Bay Area. But macular degeneration is bread and butter for any retina doctor. Usually my recommendation, if I don't know local physicians, is to go to the nearest academic institution.
The patients can also please go to macularhope.org, click on Find a Center, and they can find centers of excellence that are the best of the best as far as retina doctors in your area. So you just enter your zip code, or some more information surrounding your area, and you will be able to get that information.
Okay. I heard there is a device that is going to be released soon that will deliver the medication for 6 months and need a refill. So that was the port delivery system we talked about at the end of the slides. It was supposed to be released this year, but COVID messed everything up and delayed everything. So it's my understanding that the clinical trial results have been they've been outstanding. I suspect it'll be available next year. That's what the representatives of Genentech are telling me. I am confused with all the vitamins that are on the market. What should I be looking for? If you have confusion, because there's a lot of stuff, and you need to read the fine print, because a lot of the vitamin supplements that are offered in the pharmacy, GNC, et cetera, there's a little label on them that says this statement has not been approved by the FDA. So if it has that little label on it that it has not been approved by the FDA, it really gives the manufacturers wide latitude about what to say and what they put in it. So my recommendation would be to go for the best thing you can do if you're buying the vitamins from a pharmacy. Tell the pharmacist you need a good AREDS 2 supplement, AREDS 2. And the pharmacist can steer you in the direction of supplements that only contain the AREDS 2 formulation. If there's some confusion about the vitamins, I would steer clear of products that say that they have AREDS 2 plus a bunch of other stuff that might work for you. Look for something that says it only has AREDS 2. Some of those companies are PreserVision, iCaps, but the pharmacist in your pharmacy will be able to help you out with that. And you want to take something that only has the AREDS 2 vitamins, take that in addition to a multivitamin. And that should really simplify things, because I agree with you. There are too many products out there, and that little label that says that it's not approved by the FDA, that's usually hard to read. My dad has lost a lot of vision due to AMD. His doctor said there's nothing more that he can do. Is there a clinical equipment that might help? So if your physician has said that there's nothing more that they can do, unfortunately, sometimes that's what it comes to. If there's a lot of damage in the center of the retina is made of the same tissue as the central nervous system. It's made out of the same stuff as the brain, as the spinal cord. And, we all know stories about people that have been in car accidents and they've broken their neck and now they're quadriplegic and there's nothing they can do. It's the same idea. Once that central tissue gets damaged, if it's damaged significantly, there's no way for it to recover. And there may very well be nothing more that can be done. In those cases, we usually send patients to low vision specialists. And low vision specialists work with magnifiers and different devices that allow patients to utilize the functional retina that they still have. Because if you remember the pictures that I showed you, macular degeneration, whether it's dry or wet, is largely a disease that damages the center of the retina. It usually doesn't affect the more peripheral edges of the retina. And low vision therapies and therapists are able to harness that retina and restore function in some patients. So low vision is the path of least resistance for that. When I receive injections, my eyes turn red, swell, burn, and itch for several days. Yeah, there are a lot of idiosyncratic reactions after the injection. It's not the injection actually that's usually doing that. It's usually the iodine wash beforehand. If you are having that kind of a reaction, there's two things you can do. You can ask your doctor to use less betadine or less of the iodine before the injection. And you can also ask his or her technicians to give you a really thorough rinse at the end of the procedure to make sure that all of the excess iodine is off the eye. Between those two things, it's not going to get rid of this reaction, but it'll probably improve it. Why does the injection hurt? I do not want to go back again. Okay, it shouldn't hurt. Now, I had the slide that when I talked about anesthesia and the slide and the pain and stuff like that, there's no piece of information that applies to everybody. Most physicians pay a lot of attention to the comfort of their patients, although there are physicians out there that reason that it's a very quick procedure and it doesn't matter that it hurts for a second. If you're having pain with the injection and you like your doctor, the first thing you should really do is tell your doctor, because there are other ways to numb the eye up. For example, in our office, we usually give people viscous lidocaine drops, and we give them a bunch of drops, 4 or 5 drops over a 10-minute period of time, and then we give them the injection. For patients that still have pain just with the eye drops, what we'll do is we give them 1 eye drop, that numbs the outside of the eye, and then we give them a lidocaine or a numbing injection in the outside of the eye to give them more anesthesia. And when you have it that way, you don't feel anything, nothing. So there are different anesthetic protocols so that it won't hurt. But the first thing you need to do is discuss it with your physician, and you can let your physician know that there are other anesthetic options so that it doesn't hurt. It definitely does not have to hurt. What percentage of patients respond well to Avastin? It's similar to Lucentis and Eylea. A lot of patients respond well to Avastin. There have been a number of international clinical trials that have compared Avastin head-to-head with the other medications, and the results have shown that they're similar. So patients getting Avastin, on average, about 35–40% will have an improvement in vision. About 60 to 70% will have their vision stabilized or improved. About 30% of patients won't respond to Avastin. Is infection risk lower with PDS as a doctor service? It's a good question. The only information I have about it is based on the clinical trial, because I haven't used it at all. But it's my understanding that it's lower risk overall. And yeah, once the PDS is in place, it would have a lower risk of infection because the needle's not going into the eye anymore. It's going into the reservoir. So from a scientific standpoint, that would make sense. Thank you for, oh, well, thank you. Thank you very much. Can cataract surgery improve or make things worse for dry macular degeneration? So doing cataract surgery in patients with macular degeneration. Now, cataract as an age-related condition and macular degeneration as an age-related condition, they often coexist in patients. So this topic has come up many times, and it's been heavily debated in the ophthalmology world. And there are many smart physicians on both sides of the ball here, but most physicians will tell you that it's safe to do cataract surgery and it won't have any negative impact on the macular degeneration. Now, if it gets worse after the cataract surgery, you have to remember it's quite possible that it was going to get worse anyway, even without the cataract surgery. The cataract is a progressive, curable condition. So if the cataract gets bad enough, I always recommend that the patients have them removed. Wet AMD has already taken my central vision. Any way to get it back? If you have scarring from the wet macular degeneration, currently there is nothing that would bring back the central vision. The best you can do with the eye in question would be low vision aids. But some of the therapies that I mentioned today, particularly stem cells, could be a help to you in the future. But currently, as far as approved therapies, there's nothing that can bring it back, but low vision therapies can help you manage it better. What percentage of patients can be effectively treated and stop their injections? That's a good question. It's the minority of patients, but I can tell you that in our office, even if patients stop needing the injections, and I'm thinking off the top of my head, it's probably 5 or 10% of the patients with this, with the diagnosis of wet macular degeneration, 5 or 10% that have been able to stop. Those patients need to be monitored forever, because even if you go several years without needing it, it's possible you could need it again in the future, and we want to be there to do that if the disease reactivates. What is your opinion of Dr. Rozakis at the Macular Group? I am not familiar with Dr. Rozakis. Can't comment, sorry. Is a retinal hole the same as a retinal tear? They're very similar. If you want to think of the retina as wallpaper, a retinal hole would be a hole in the wallpaper. A tear would be a piece of the wallpaper tears down. They end up both putting you at risk for retinal detachment, so they're very similar. I saw a flashing of electrical spark that can make you blind. If it's a flash that you subjectively saw, the flash itself won't make you blind. The concern about seeing flashes is that it can be related to the development of retinal tears and detachments, which if those are occurring and they're not properly treated, that can make you blind. But if you're just seeing flashes, all you need is an eye exam and let someone make sure there isn't anything else going on. Any evidence out there that the SAD lamps damage the macula? I don't know. I've heard some stuff about it, but I don't know any of the science on it. Is there any role for testing contrast sensitivity or dark adaptation to identify patients with not with macular degeneration. That's more for inherited retinal disease. Contrast sensitivity would be more appropriate for cataracts, but not for macular degeneration. Any data on doing hyperbaric chamber with oxygen improving wet macular degeneration? It's been used for other retina vascular diseases. To my knowledge, it hasn't been used for macular degeneration. I don't know that low oxygen is thought to be incriminated in the progression of this disease. It's more related to inflammation. I don't know that it's an issue that hyperbaric oxygen would solve, but it has been used for other retinal issues for sure. What about, I'm not familiar with using acupuncture for this condition. I can't comment on it. How high is the risk of stroke if I'm getting Avastin injections on a long-term basis? It's not, there's not a high risk of it at all. As a matter of fact, the data is equivocal. There's no data to say definitively that it causes it. The problem is that there's no data to say that it has nothing to do with it. It's that in the middle that gives people concern, but it's definitely, I would not classify it as a risky procedure, and there's no, the risk of having a stroke does not accrue on a long-term basis. So it's very, very low. 4C Home only works for dry AMD. Is there something that works for a combo eye? I've had bleeds in both eyes, and last month I went from 2060 to 2400 in 1 month. The other eye is 2030, so I didn't detect it even though I use the Amsler grid every morning. They will be discussing the 4C Home a little bit later, and they can answer your questions in more detail. Sorry to hear about that, though. What about the favorable clinical studies using OcuPower? I am not familiar with OcuPower. I can't comment on that. How long will it take for stem cell therapy to be available to the general public in the US? I would say 5 to 10 years. It could potentially be pushed back more because of COVID.
I'd like to thank you so much, Dr. Green, for answering all those wonderful questions and for the great presentation. We are now going to turn our attention to Dr. Megan Blemker. Dr. Blemker is an ocular disease residency trained optometrist who practiced in Nashville, Tennessee for 9 years before transitioning to industry. She was an executive clinical outcome specialist with Bausch & Lomb Surgical for 4 years prior to joining the Notel Vision team a little over 3 years ago, where she serves as Director of Clinical Affairs and Professional Relations. Dr. Blemker, you have our attention.
Thank you so much for the introduction. Notel Vision is proud to partner with the Macular Degeneration Association, and I appreciate the opportunity to speak to you all today. It is such a privilege. To reiterate some of the important points made in the presentation, I'd like to further discuss understanding the importance of early detection of wet AMD and how you can play a role in protecting your vision. 4C Home is FDA cleared and Medicare covered. It's prescribed by your eye care professional when you have the appropriate level of vision and appropriate stage of age-related macular degeneration. It's a form of personalized medicine with the 4C Home device used at home in between your regular eye exams, and it detects metamorphopsia or visual distortions in AMD. AMD is the leading cause of severe central vision loss in people over the age of 50 years in the United States. I'm going to share with you the information you need to get informed and take charge of your vision. AMD is a chronic, meaning it doesn't resolve or go away, progressive, meaning it tends to worsen over time, type of condition. And there are 2 types of AMD, dry and wet. Dry AMD is the slower changing, earlier form of the disease that puts you at risk for developing the wet form of AMD. And wet AMD is the sudden change or advanced form of the disease. AMD affects an area of the retina called the macula, which is responsible for detailed central vision used for activities like reading, driving, and seeing faces clearly. In dry AMD, changes occur in the cells of the macula, and drusen or deposits, these yellow spots that you see here on the right side of the screen in the picture, build up in this area. And these changes may induce blurry vision, such as difficulty seeing sharp details both up close and far away. Dry AMD is the slow form of the disease, with changes you may not notice over time. Most importantly, dry AMD puts you at an increased risk of progressing to wet AMD. Over time, the size and number of these drusen or deposits can increase, which increases your risk of developing the more sight-threatening form, wet AMD. Again, dry AMD can suddenly change to wet AMD without any kind of advance notice. If you convert to wet AMD, abnormal blood vessels grow under and into the retina in the macula, as you'll see here on the right side of the screen. These blood vessels can leak fluid, and they can sometimes bleed without any type of warning. You may not notice these changes until significant vision loss has occurred. If you convert to wet AMD, this significant vision loss can be rapid and severe. Symptoms of wet AMD include distortion, where straight lines look wavy. You can have dark spots in your vision, or just generalized blurry vision, as you see here on the screen. Unlike dry AMD, there are effective treatments for wet AMD, but these treatments are most effective when administered early on before symptoms are noticed and before vision loss has occurred. These treatments can halt or slow the progression of wet AMD, but they cannot restore vision that's already been lost. Once the wet disease starts, it will continue to advance until you receive treatment. Irreversible damage can occur within days to weeks and before symptoms are even noticed. But how early is early detection? Once symptoms of visual impairment are noticed, those wavy lines or dark spots appear in your vision, then the vision loss may have already occurred. The earlier you catch wet AMD, the better chance you have of preserving your vision, your independence, and the ability to go about your daily life participating in activities you enjoy. So, wet AMD treatments are most effective when the disease is caught early. 4C Home is an early warning system for your eyes. You use this device at home in between your regular eye exams. It helps people with dry AMD detect wet AMD before you even notice that visual changes have occurred. But how does it work? Well, you take a simple daily test that checks for tiny changes in your vision. The test takes just a few minutes per eye per day. The data from each test is then sent to your eye doctor as well as the No-Tal Vision Diagnostic Clinic, the medical provider of 4C Home. If a change in test scores is detected, the diagnostic clinic alerts your doctor. Your doctor's office will then contact you directly to schedule a follow-up visit. The Amsler grid, as you see here on the left side of the screen, was developed in the 1940s and has for a long time been recommended as a simple and accessible tool that you can use from home to monitor the changes in your vision. However, by the time you notice vision distortions on this Amsler grid, significant vision loss may have already occurred. Fortunately, new technology such as the 4C Home AMD monitoring program has been developed so you can detect tiny changes before symptoms are noticed, and the system reports them to your doctor so you can receive immediate examination and treatment if necessary. Testing with 4C Home is easy. You turn the device on and look into the viewfinder to begin testing. Then a bump will briefly appear and disappear, as you can see here in the center green circle on the screen. You'll use the mouse provided to click where the bump appeared and then return to this center dot. Data from each test is then sent to the No-Tal Vision Diagnostic Clinic for evaluation and provided to your eye doctor as well. Regular at-home monitoring is like brushing your teeth. It's just a good, healthy habit you do every day to help preserve your vision. 4C Home allows you to take a proactive approach to protect your vision. A clinical partner will be with you every step of the way. After the No-Tal Vision Diagnostic Clinic receives a referral from your doctor, we'll answer any questions, verify coverage, and ship your device. Once you receive the device, the No-Tal Vision Diagnostic Clinic will walk you through setup and training. You and your doctor will continue to receive feedback from the No-Tal Vision Diagnostic Clinic. Our team will be sure to verify your insurance benefits and discuss with you prior to your acceptance of the device and prior to getting started with the program. There are low out-of-pocket costs for Medicare patients. So patients with Medicare and a secondary supplement plan could have out-of-pocket costs as low as $0 per month. Patients with Medicare and no secondary supplement plan will pay $15.06 per month once their yearly Medicare fee-for-service Part B deductible is met. Again, 4C Home is FDA cleared and Medicare covered. Your doctor will send our No-Tal Vision Diagnostic Clinic the order for you to begin the 4C Home AMD monitoring program. And appropriate candidates have a particular stage of dry AMD and a particular level of vision, which will be determined by your doctor. You'll continue to test regularly at home. If a change takes place, your doctor will be alerted and have you come in for an examination. In summary, the No-Tal Vision Diagnostic Clinic works with your doctor to remotely monitor your dry AMD, helping you retain functional vision throughout your AMD journey. I'm happy to answer any questions you might have, and thank you so much. Here's my contact information for your reference. I would love to hear from you. Great, we'll just switch to the Q&A here. I agree with Dr. Green. There's some wonderful questions that came in. The first one here is, my doctor said they've never heard of this program. How can I get this? I would say the first thing to do would be go back to your eye doctor and let them know you attended this program and you learned about 4C Home and that you are interested in learning if you are a good candidate for the program. And similar to the physician finder on the macularhope.org on the Macular Degeneration Association website, we also have a physician finder function on our website. It's at 4chome.com, so you can find more information there. The next question is, I was just diagnosed with macular degeneration. My doctor handed me the grid. Why not your product? Well, as we've learned in the presentations today, the Amsler grid has been around for some time, and it is currently the standard of care. And one of the ways that you can monitor your vision at home between office visits, we're of course very excited that this new and much more sensitive and a better way to detect any changes to your macular degeneration earlier with 4C Home is available. And so we would like to encourage you again to go back to your doctor, talk to them about 4C Home, again, see if you're a good candidate, and then you would use 4C Home in addition to whatever your doctor is already recommending. So as far as your follow-up examinations, any kind of supplementation, I know Dr. Green talked about that today, anything else that the doctor is asking you to do, including the Amsler grid. So this would be 4C Home in addition to Amsler grid and everything else that you're already doing. We want to give you the very best chance to detect any conversion or any change from that dry to the wet kind as early as possible to help preserve your vision. How much will the program cost me? We actually have a full team of patient financial services who would be able to obtain your insurance information. So once your referral information sent from your eye doctor to our No-Tal Vision Diagnostic Clinic, at that point in time, that patient financial services team of ours will look at your insurance information and see what, if anything, you would have to pay every month because it's a recurring payment model for the monitoring service. So this is Medicare cleared and FDA covered. If you have any kind of supplemental insurance, they would look into that as well as far as any copays that you might have. But this is something that would absolutely be discussed with you before we would ship you the device. So there's no obligation. If you want to inquire about obtaining the device, then we could discuss this with you. And if you decide you want to move forward, then that's the time where we would ship the device to your home and get you started, get you trained on how to use the device and monitor you from there. How accurate is the test? Well, we're very proud of the home study results. So I know Dr. Green had mentioned some studies, including one of the big supplement studies, the AREDS, Age-Related Eye Disease Study. So we had a very large clinical trial that was an ancillary kind of a subset of that study that showed how effective 4C Home was. But like any test, there are some false positives or false negatives, meaning there's nothing that's 100% accurate. However, when patients were using 4C Home in addition to the standard of care, in addition to what their doctor was already recommending within that study, 94% of patients maintained 20/40 or better vision. 20/40 is a level of what we call functional vision, where you're looking at the chart and you're able to see some of the smaller lines and you're able to drive and watch TV and read and do the things that you enjoy doing. So, so we have the clinical trial data to back it up as a very effective tool when you add that to what your doctor's already recommending. Next question is, my hands and head shake. Will I be able to use this machine? I think this is a very valid concern. And again, since there's no obligation with our program, meaning that if we ship you a device and then you give it a try, you work with our team over the phone to be trained on using it, but you're just not able to, we will happily take that back. We'll provide shipping, labels, boxes, etc. As far as being able to use it, definitely we would work with you, and depending on how comfortable you could get and how still you could get using the viewer and clicking the mouse with your index finger, the mouse that comes with the 4C Home, again, our team would be happy to coach you. And if it just so happens it won't work out for you, we will take the device back at no charge to you. Can you test both eyes at once? Very good question. So we want to make sure, since one eye takes care of the other, oftentimes with your vision or your visual system, that we are just checking one eye at a time. So if you're a good candidate for 4C Home in both eyes, what would happen is the viewer would be set when it comes to you, it's automatically covered in one eye, and then you're testing with the other eye. So for example, you test the right eye first. So your face is in the viewer, you're clicking the mouse, you test the right eye, and then it will rotate so that you can test the left eye. If it so happens that you're only a good candidate for one eye with 4C Home, then we will have our technicians set it as such before sending it to you. So it's very easy just for you to get into the test and get going with it, be able to monitor yourself. Is this product available in Canada? At this time, this is only available in the United States. When I do the test, will I be given the results, or will they go to the doctor only? Wonderful question. So what happens with the test results is they go to our no television diagnostic clinic, to our cloud. At that point in time, of course, the artificial intelligence, that algorithm, is analyzing, where did you start? Where are you now? Has something changed? Is there any cause for concern? Do I need to alert? And by alert, what happens is the information goes from our diagnostic clinic to the physicians. They have access to your information. They can look at that at any time. It's almost like they are able to examine you every single time you test, because they have access to that information. But you would receive word from your physician if they have gotten a notification from us, from our no television diagnostic clinic and from the technology, to bring you in. So it would be, the device takes the information to the cloud sends the information to the doctor. And then if the doctor has cause for concern from the device information, then they bring you in for examination and go from there. Great questions. How long does testing take with 4C Home? We say a few minutes per eye per day. So it depends on how comfortable you are with the viewer and how quickly you do the test. There's absolutely no rush to take the test, but like with anything else, if it's new, it may take you a little bit longer once you get started. But then after you've done it several times, especially if you do this as a daily habit or several times a week habit, then you're going to become much more proficient at it and more efficient. So you'll be able to perform it more quickly. But we say a few minutes per eye per day. When will 4C Home work for people that have dry and wet combinations? So I'm assuming you mean dry in one eye and wet in the other eye. So at this time, 4C Home is only designed for and indicated for that dry stage, that intermediate or kind of medium stage of age-related macular degeneration, and a certain level of vision. Both of those would be determined by your eye care professional. As far as the wet type of AMD, we have a product that is investigational only. So of course I can't make any claims about it, but in our pipeline technology, we have a home OCT that is currently in US clinical trials. And there's more information about the home OCT on our website, but similar to the scans that you get at the office, every time you go in to see your doctor, it would be able to perform a scan at home. And in the same fashion as 4C Home, send it to the cloud, and the cloud sends it to your doctor. But stay tuned for more information on that, as it is in clinical trials. For dry age-related macular degeneration, 4C Home is going to be your best bet to help preserve your vision, detect any changes earlier. Next question is, once you have wet macular degeneration, can you still use this machine? And this kind of relates to what I had just mentioned about the two technologies, the one currently approved and the future one, or the pipeline technology. Because they're designed for very specific disease states, they have to be specific to that type of age-related macular degeneration. So again, you'd have to have the appropriate stage and the appropriate level of vision. Oh, what a great message. Thank you. Thank you. This machine has saved my vision. My eye turned to wet. I needed injections, but my vision has come back. I'm a true believer. Thank you so much for sharing that story. Of course, this always warms my heart when I hear these stories. This is why we do what we do. And it's such a privilege to be able to help support your eye care and help preserve your vision. So thanks for sharing your story. Oh, and thank you. So thank you for the information. Thank you all for your attention. I really appreciate it. And then let's see. Great question about, can the 4C home be used to guide the doctor about the frequency of the Eylea shots or of the injections that go into your eye when you have wet age-related macular degeneration? Again, I can't make any claims because it's investigational, but of course this would be something that potentially the home OCT, since it would be monitoring wet disease, that would be a notification from that type of technology and perhaps help customize your treatments. I know, as Dr. Green had mentioned, there are very different formats as far as when you need an injection into your eye or just how frequently you need them and which type works the best. So all of that is still to be determined. And of course, it's very different from person to person, but very exciting that we have these things on the horizon, be able to help with that. Is the data that you collect from 4C Home shared with any third parties? So we are very cognizant of HIPAA regulations. And so anything that is, since we are a provider, so we have a national provider identifier, we are an independent diagnostic testing facility, we are Medicare credentialed, so we are a provider just like your eye doctor. And so the information between our teams is strictly within the HIPAA guidelines and it's not shared elsewhere. It's very, very secure. And the last question, will 4C Home ship the product and service to people living in Canada? Unfortunately, at this time, it's only available in the United States, but appreciate the question. Okay. I think that's all for today. Fantastic questions. Thank you all so much for your attention. I hope you're able to take some of this valuable information with you. And like I mentioned earlier, if you would want to reach out to me, I would love to hear from you. So thanks so much for your time and have a wonderful day.